Okay, welcome back. Can you hear? Can you hear and see me? Yes. Okay. Okay. Now let us finish off with some hereditary cause of jaundice, which is very important. So later on tomorrow, maybe we can start with the liver failure causes and move on about acute and chronic hepatitis, including viral hepatitis. So today is hereditary cause of jaundice because we are in the zone of understanding jaundice. So what are the hereditary cause of jaundice? So first, unconjugated. Unconjugated hyperbilirubinemia is due to, hereditary causes wise, you have three causes. Two causes, Gilbert and Crigler-Najjar. Crigler-Najjar has two different types, type 1 and type 2. That's what we're going to see. So first one is going to be the Crigler-Najjar type 1. And second is Crigler-Najjar type 2. And third one, we can talk about the Gilbert syndrome. So why I'm actually putting in this order is because of the severity of the conjugation defect. So in all these situations, in all these things, the primary problem is the conjugation defect. Conjugation defect, that is UGT1A1 defect. That is the UDP glucuronidase transferase enzyme problem. So how much is what the question is here. So if you ask about the Crigler-Najjar type 1, it's going to be the most severe form. You can call it as something also moderate severity, Crigler-Najjar type 2. As far as the Gilbert is concerned, is the most mildest form, very, very less severe. Inheritance wise, all of them are autosomal recessive. Everything is autosomal recessive in the sense like including Crigler-Najjar type 1, type 2, Gilbert, all are autosomal recessive inheritance. So you can tell all these things in a common one. So what is the amount of activity of the enzyme that will be seen? Remember, in Crigler-Najjar type 1, there will be literally no activity of the enzyme. But whereas in Crigler-Najjar type 2, you will have approximately less than 10% activity. Some will be there, which means some activity is there, at least not 0%. But in type 1, you don't have any activity of the enzyme at all. Whereas in Gilbert syndrome, usually it will be more than 10% activity. So a good activity of the enzyme is there, but it's still defective. So that's the idea of Gilbert syndrome. As far as the serum bilirubin is concerned, typically in Crigler-Najjar type 1, the bilirubin levels will be more than 20. Most of them we know it's unconjugated. And in type 2, it will be less than 20, maybe around 15, 18, but it will usually don't cross 20. But in Gilbert syndrome, usually it will be in the range of 3 to 6 milligrams per deciliter. It will not exceed 3 to 6. Usually it will be 1.8 to that much only, but in stressful scenarios, it can go up to 4, 5 and all, but it will never exceed 6 milligrams per deciliter. So age of onset of jaundice, when the jaundice will come, typically in the setting of type 1, it happens during the newborn and infantile period itself. The jaundice onset will be in children. Typically, Gilbert syndrome will be manifesting only in adults, so which is very important. As far as liver enzymes are concerned, all of these three things will have normal liver enzymes. I told you ALP, AST, ALT, everything will be normal, which means it's not liver cell injury. This is just a conjugation defect. So liver enzymes technically will be normal and should be normal. And if you talk about a phenobarbital effect, previously we have been talking about alcohol also. If you give phenobarbital, effect of phenobarbital, in a type 1, typically there will be no effect because phenobarbital is basically an enzyme inducer. You know that. Even alcohol is an enzyme inducer. Technically speaking, an alcohol can do the same thing what phenobarbital is doing. But if you give a phenobarbital, typically there will be no effect. Why no effect? Because there is no enzyme to induce. But whereas in the setting of Crigler-Najjar type 2 and in Gilbert syndrome, there will be decline in the bilirubin. After giving phenobarbital or probably even after taking alcohol, patient may experience a decreased bilirubin. So why this is happening? Because there is at least some enzyme in these two situations where this phenobarbital or alcohol can induce that enzyme and they can activate them, resulting in more conjugation and resulting in decline in the serum bilirubin. As far as the bile composition is concerned, there will be increased, no glucuronides at all because this is absolutely defective enzyme, 0% activity. There will be no glucuronides at all. No conjugated components will be there in the bile. Whereas in the setting of type 2, there will be increased amounts of monoglucuronides, but diglucuronides will be absent because it's defective. they can do one step of glucuronidation, but the second step will be completely defective. So once again, in Gilbert syndrome, there will be increased monoglucuronides, but here it will be more compared to Gilbert syndrome. But in the setting of type 1, because it's absolutely no enzyme activity, there will be no glucuronides, mono or di, it will not be there at all. As far as liver biopsy is concerned, completely normal liver biopsy. There is no problem at all. So you not do really, because the enzymes are normal. Why you need to do a liver biopsy? It will be completely normal liver. And treatment. So the cause of death in Crigler-Najjar type 1 is the kernicterus. That's the usual reason for death, because infants do not have that powerful blood-brain barrier. So this unconjugated bilirubin can easily cross the blood-brain barrier and they can deposit in the basal ganglia, causing kernicterus. So here the mainstay of therapy is the phototherapy. That's the most important therapy. Typically we keep for 8 to 16 hours per day, which is the most important. And there are some other options are there. Like for example, we have something called calcium carbonate. You would have studied in pediatrics that this calcium carbonate basically enhances the effect of phototherapy. And plus or minus, you can add plasma exchange. Especially this plasma exchange may be needed during illness. During illness is needed, especially because during illness, your albumin level will drop, because albumin is something that carries the unconjugated bilirubin. Suppose during some systemic illness, if albumin levels drop because it's a negative acute phase reactant, the amount of unconjugated bilirubin that can bind with albumin is actually less. So there will be a natural increase in free unconjugated bilirubin. So that will actually become a problem, because that can again cause deposit in the brain, causing some issues, kernicterus-like issue. So again, only during illness, you can actually use a plasma exchange to increase the serum albumin. Plus, at the same time, the definitive treatment, if they ask you only one thing, that is liver transplantation. That is the only definitive option, because you replace the abnormal liver with a normal liver. But nevertheless, apart from this conjugation defect, there is no problem in the liver function in these three disorders. Absolutely no problem. PTNR will be normal. Albumin will be normal unless and until there is systemic infection. So apart from that, everything will be normal. Only thing is they cannot conjugate the bilirubin. That's the only problem. Type 2 is not very severe. Severity is variable. Usually they don't need any treatment. Gilbert definitely don't need any treatment. But type 2 usually don't need any treatment, but only during illness. During illness, especially in childhood, there is small increased risk of kernicterus is there that you have to manage. Especially in infantile period, especially if they get some neonatal sepsis or something, because during sepsis, the unconjugated bilirubin will rise and albumin levels will be dropped. So that is the time where unconjugated bilirubin can become more than 20. Remember, usually it will be less than 20 in these disorders. But sometimes during illness, because of the loss of albumin, and naturally it's a kind of state where bilirubin production will be a little accelerated. So your unconjugated bilirubin can exceed 20 during the time of illness alone. So during that time only, there is a small risk of kernicterus if it's an infantile population. So that time you need to give some treatment. Apart from that, there is no need to treat anything at all. Again, Gilbert syndrome, because it's absolutely benign, you don't need any treatment at all. But there are some drugs that are actually metabolized by UGT1A1. So certain drugs can have increased toxicity in patients with Gilbert syndrome, especially drugs like irinotecan. Because this is one drug that is actually metabolized by glucuronidation. So because UGT1A1 is very, very important for metabolizing these drugs, and there are some other drugs also, but the most important drug, because this is used in cancer. So this drug toxicity can be a little bit higher in patients with Gilbert syndrome, because this drug is basically metabolized by UGT1A1. So that is the reason. And at the same time, there is one interesting info that unconjugated bilirubin excess in patients with Gilbert syndrome is thought to be protective against cardiovascular disease, because we believe that unconjugated bilirubin is actually a kind of an antioxidant. So it can actually reduce the risk of atherosclerosis and reduce the risk of cardiovascular disease. And it's been proven in many trials also, like Gilbert syndrome patients have 6.5% reduced risk of developing cardiovascular death and MI compared to the general population. This is an interesting info, but usually by any means, they won't be asked in exams for sure. Don't worry about that. So these are differences between the three hereditary causes of unconjugated hyperbilirubinemia. But we have two hereditary causes of conjugated hyperbilirubinemia. One is called as a Dubin-Johnson syndrome, and second is something called as a Rotar syndrome. These are two important conjugated causes of hyperbilirubinemia. So once again, as far as the inheritance is concerned, it is autosomal recessive, both these conditions, and both are extremely rare. It's not common at all. But Gilbert syndrome, on the other hand, it's extremely common. You can see in some areas, you can see up to 5% in general population itself. So it's very common. But Crigler-Najjar type 1, type 2 are again very rare. We don't really see that much. And what is the defect? What is the problem? Where is the problem? Defect in Dubin-Johnson, we know it is typically MRP2. That is the C-mode, canalicular multi-specific organic anion transporter, or called as multi-drug resistant protein 2. This is a defect. So it's a secretion defect. So here in rotor syndrome, we don't know the defect really. Probably they think it's might be a glutathione S transferase defect. That's called GST defect. So, but here we think in Dubin-Johnson, it's more of a secretory defect, which is very clear, where MRP2 doesn't work. So the conjugate bilirubin cannot be secreted into the bile. But here, again, we don't know what is the primary defect. We think it's an uptake defect that is associated with a secretory defect because again, it's very unclear. So why you get a rotor syndrome? So we don't know really. There are some postulates are there, but we don't really know why rotor syndrome is there. Typically, the serum bilirubin levels in Dubin-Johnson syndrome will be in the range of 3 to 6. Once again, even in rotor syndrome, it will be in the range of 3 to 6, not that much high bilirubin. Similarly, it is conjugated only. So that is the reason why they won't cause connectors in the first place, because it's conjugated. They're water soluble. Why they should deposit? Why they should precipitate? So they won't get any connectors and all. And again, liver enzymes wise, completely normal. So with abnormal liver enzymes, you cannot diagnose a hereditary cause of hyperbilirubinemia. And more importantly, there is something called a brown-black liver, or sometimes referred to as a black liver in textbooks. That is quite a feature of a Dubin-Johnson syndrome, but it will not be a feature of a rotor syndrome in the first place. You will not see that. So why you think you get a brown-black liver in the first place is because in Dubin-Johnson syndrome, there is one more problem that actually causes accumulation of this polymerized epinephrine molecules in the liver. So that is actually the reason why. That is due to accumulation of polymerized epinephrine molecules. That happens in patients with Dubin-Johnson syndrome only. So if they ask you in exam which of the following conditions which is associated with the brown-black liver, then probably you can go for Dubin-Johnson syndrome. And there are some other few ways to differentiate. For example, we have something called coproporphyrin levels. We're talking about total coproporphyrin, which will be normal in the setting of Dubin-Johnson, increase in the setting of rotor syndrome. And coproporphyrin fraction is there. Coproporphyrin fraction in patients with Gilbert syndrome, in patients with Dubin-Johnson syndrome, the coproporphyrin fraction will be 1 more than 3. Normally, typically 3 will be more than 1. This is normal, but in patients with Dubin-Johnson syndrome, 1 will be more than 3. So that will be reversal of the coproporphyrin fraction. That is quite characteristic of a Dubin-Johnson syndrome. Whereas in patients with rotor syndrome, 3 will be more than 1. This is a normal thing. So normal fraction will be 3 more than 1 only, but in Dubin-Johnson alone, there will be a reversal. 1 will be more than 3 due to many obscure and unknown reasons, and it can be explained, but it's not needed anyways. Typically, when you talk about a HIDA uptake, HIDA scan uptake typically will be there in the setting of a Dubin-Johnson syndrome, but it will not be there in the setting of a rotor syndrome. That is the reason why we believe that rotor syndrome also has an associated uptake defect also. As far as HIDA excretion is concerned, whether it's excreted or not, excretion is defective in the setting of Dubin-Johnson syndrome, but excretion will not be there. If there is no uptake, how they can excrete? It's not possible. Excretion is also not there in rotor syndrome. But remember, uptake will be there, but excretion will not be there, suggesting it's a secretory defect. HIDA is basically like a bilirubin only. So you can remember HIDA like a bilirubin only. So the liver sees HIDA metabolite as a bilirubin only. So they take up and they excrete like bilirubin. So they conjugate and they excrete like a bilirubin. So here uptake will be there, but excretion will not be there. But here uptake and excretion both will be defective. And there is something called a BSP test. That's called a bromosulfalin test. As far as bromosulfalin test is concerned, there will be a very slow elimination. Plus there will be a secondary peak. So I don't know, only one time they've asked this question. Slow elimination with secondary peak is suggestive of a Dubin-Johnson syndrome. Here also there will be a slow elimination, but without a secondary peak, with no secondary peak. Slow elimination without secondary peak is what is something you're going to get in a rotor syndrome. So these are some differences, but many things won't be asked in exam. But only thing probably they will be asking exam is this BSP only. That's called a bromosulfalin test. So where there is a slow elimination with secondary peak is suggestive of a Dubin-Johnson syndrome, whereas slow elimination with no secondary peak is suggestive of a Rotar syndrome. So these are the things that you need to know. Again, you can explain all these things, but it's absolutely not needed. In exam, whenever you see a conjugated bilirubin with normal liver enzymes without any signs of liver cell failure, you think about a Dubin-Johnson or a Rotar syndrome. So this is the final take-home point. So Dubin-Johnson will have a brown-black liver. So if they also give in biopsy, you see a brown-black liver, it is Dubin-Johnson, it's not Rotar. That's all. This is the usual thing you will get in exam. Apart from that, the bromosulfalin test once they asked in exam, but apart from that, you don't really need to know. So remaining thing just for a knowledge I've told you. Apart from that, you don't really need to know other things. So these are difference between Dubin-Johnson and Rotar syndrome. Next, we have some other causes which can actually cause liver cell failure, but these are congenital cause of hyperbilirubinemia. Till now, we have talked about only congenital cause of hyperbilirubinemia, which will not cause any liver failure or any liver issues. But now we are going to see some congenital hyperbilirubinemia, which can cause problems in the liver as well. So this group of disorders, the first group of disorders are called as familial hepatocellular cholestasis. Familial hepatocellular cholestasis. We have many distinguished disorders under this, and we have Alagili syndrome also, which we'll be discussing in some time. So in that we have two types of disorders. One is we have something called benign recurrent intrahepatic cholestasis. Benign recurrent intrahepatic cholestasis. And second one is something called a PFIC. That's called a progressive familial intrahepatic cholestasis. Both of these things have three types. Both of these things are having three types. PFIC type 1 to 3 and benign recurrent intrahepatic cholestasis also having types 1 to 3. In that, PFIC is the most important for exam. That to one type of PFIC they will ask, that is Bailer's disease. That's called as Bailer's disease. That's a type 1 PFIC. That's very common question in exam. So PFIC type 1 to 3 is what I'm going to discuss right now. This is not at all important for your exams. Nobody is going to ask. These are two conditions which cause cholestasis. At the same time, they can cause liver injury also, and they can cause elevated bilirubin as well. And in that, we are going to see three types of PFIC. PFIC 1, PFIC 2, and PFIC 3. But let us, before seeing the different types of PFIC, let us see what happens in the canaliculi basically. So we have this bile canaliculi where many different proteins are important. So let me assume this is the bile canaliculi. And we know the traditional MRP2 transporter. So we have the MRP2 that is important for pushing the conjugated bilirubin. But more importantly, why this MRP2 is called C-mode? Because it's an organic anion transporter. So it doesn't only transport the bilirubin glucuronides, it also transports something called GSH. Clear? And it also transports other organic anions. Hello? சொல்லுங்க. வாட்ச்மேன் கொடுத்துருங்க பாஸ், அங்கே செக்யூரிட்டி A102. அதான் ஓகே. So bilirubin glucuronides, GSH, and many organic anions can also be transported by this MRP2 multidrug resistant protein. We know the defect in this is what we called as a Dubin-Johnson syndrome. Clear? So Dubin-Johnson is basically due to the defect in the MRP2 transporter. But we have many other transporters that is important for secreting bile salts, bile acids. So bile does not contain only conjugated bilirubin. Bile also contains bile salts and bile acids. Who's going to do that? So let us talk one by one. The first one, maybe we can talk about, there is one transporter. There's a very important transporter that's called the BSEP transporter. BSEP transporter, which has multiple different names, also called as ABCB11. I'm not going to talk about that, which is the one that's going to transport the bile salts. Clear? The defect in this BSEP transporter is what is going to result in something called PFIC type 2. That is called a progressive familial intrahepatic cholestasis type 2. Then we have another transporter called as FIC1. So I can write FIC1. This is familial intrahepatic cholecystitis type 1 transporter, or typically referred to as ATP8B1 transporter, which is going to secrete this phosphatidyl serine into the bile, which is also important for bile. So which is going to typically cause this PFIC type 1, that is progressive familial intrahepatic cholestasis type 1. And the next one is going to be the ABCB4 transporter, otherwise referred to as MDR3, multi-drug resistant protein number 3, MDR3 transporter, which is going to secrete phosphatidylcholine. I can write PC. So this is also important in bile. So defect in this MDR3 transporter is what is going to result in something called a PFIC type 3. That is called progressive familial intrahepatic cholestasis type 3. Hello? Hello? Progressive familial intrahepatic cholestasis type 3. So now you know different types of transporters are there, which are going to regulate different movement of different compounds apart from the conjugate bilirubin. We have bile salts, we have phosphatidylserine, we have phosphatidylcholine. Each and everything is managed by 3 different transporters: BSCP, FIC1, MDR3. So many transporters are. Defect in each and every of these transporters can result in different kind of an issue. So that's what we need to know. So next thing what we need to see is what are the differences between PFIC type 1, that is also referred to as something called a bileless disease. It's a very common question in PG exams, but currently you don't have any distinction between PGI, AIMS or JIPMER. So usually bileless is an extremely common question in PGI. They asked them 3-4 times in the last 10 years, and AIMS one time they have asked. So that's why bileless is very important. PFIC type 2 is there. And then we have a PFIC type 3. Then we have a PFIC type 3. So you know what is the defect? In PFIC type 1, the defect is FIC1, or otherwise referred to as ATP8B1 molecule. And PFIC type 2, the BSCP is the problem, so which is otherwise referred to as ABCB11 transporter. And PFIC type 3, you know, it is MDR3, which is also called as ABCB4 transporter. So this is the defect in these conditions. And what is the thing that it's actually transporting? I mean, what is the name it is? So what are things that are transporting? So here it's going to transport this phosphatidylserine. We saw that already, and otherwise referred to as phosphatidylserine flippase. So BSCP is nothing but bile salt export protein, which means they are going to export the bile salts. That's why it's called the BSCP, bile salt export protein. And MDR3 is going to basically secrete phosphatidylcholine, or otherwise referred to as lecithin. The other name for this phosphatidylcholine transporter is also called as lecithin floppase. So this is flippase, this is floppase, this is a BSCP, that is bile salt export protein, that is PFIC type 2. So if you talk about the enzyme elevation, next enzyme elevation, usually in PFIC type 1, it will be mild increase, whereas in PFIC type 2, it will be a moderate increase, where in PFIC type 3, there will be a severe increase. So what is the enzyme that will be predominantly elevated? That is alkaline phosphatase, elevated in all these 3 settings: mild, moderate, severe, in these 3 different disorders. And bile acid elevation is seen in all these 3 disorders. There is no doubt serum bile acids will be elevated. We're talking about serum bile acids, which will be elevated in all these 3 disorders. And we have gamma glutamyl transferase levels. This is quite important because, and quite interesting as well, because gamma glutamyl transferase levels will be typically normal in PFIC type 1 and type 2. It will be elevated only in PFIC type 3. Whereas in PFIC type 1 and type 2, the gamma glutamyl transferase levels will be typically normal. And serum alpha fetoprotein levels, it will be normal only in PFIC type 3, whereas it will be elevated in PFIC type 1 and type 2. And we see the biliary phospholipids in the bile. Biliary phospholipids. Typically, the biliary phospholipids will be normal in the setting of type 1 and type 2, whereas it will be decreased in the setting of type 3. Talk about the pruritus, that is because of elevated serum bile acids. It's going to be very severe in type 1 and type 2, whereas it's going to be moderate only in type 3. And whereas liver biopsy, if you see, typically they'll be showing biliary cirrhosis only. Whereas in type 2, there will be biliary cirrhosis with giant cell formation. Plus, you will see a lot of giant cells as well. That's characteristic. In type 3, there will be biliary cirrhosis. At the same time, there will be ductal proliferation. Biliary duct proliferation will be there. These are some characteristic biopsy findings in type 1, type 2, and type 3. The bile appearance, bile will actually grossly, if you see the bile, it will look like it will more of coarse and granular appearance. Whereas in type 2, it will be more of an amorphous appearance. In type 3, it will be more of a needle-like crystal appearance. Progression to cirrhosis, how fast or how slowly they will progress to cirrhosis. In type 1, within 2 to 7 years after birth, they will progress to cirrhosis. It's a type of biliary cirrhosis only. In type 2, around 6 months to 10 years, somewhere around 6 months to 10 years, they will progress to cirrhosis. In type 3, it is, again, its window is very wide. It takes around 5 months to 20 years to progress to cirrhosis. And treatment-wise, all these conditions, you can use UDCA. That's called ursodeoxycholic acid, can be helpful, but the best option is only liver transplantation. You have to go for orthotopic liver transplantation. So, but one surgical procedure has been alternative to the liver transplantation. In short term, one surgical procedure will be effective. That's called a PEBD. This is the question that's asked in PGA 2 times. So what is the treatment of choice for this PFIC types? Any type of PFIC can be treated with PEBD. That's called a partial external biliary diversion, also called as cholecystogeginoecutaneostomy. So that's what you're going to do, cholecystogeginoecutaneostomy, or otherwise referred to as something called a partial external biliary diversion. That's what you're going to see. And because almost all of these patients will have cholestasis. Because of cholestasis, they will have pruritus, which is very common. And second thing, most of these patients will have fat malabsorption along with vitamin K deficiency, which can result in bleeding also. Vitamin K deficiency. In exam, usually a very young child plus family history of liver disease, having pruritus, fat malabsorption, vitamin K deficiency. Fat malabsorption in the sense this can present with diarrhea and steatorrhea. So if you have these kind of issues, young child, family history of liver disease, along with the severe pruritus, fat malabsorption, vitamin K deficiency, which goes towards cholestasis, which means the congenital cholestasis, you can make a diagnosis of PFIC types. This is the clinical scenario that will get in exam. Apart from that, how to tell surely that it's a PFIC one, because biology is something that's going to be very commonly asked in exam. How to know that this is PFIC for sure? Even though I told you everything for knowledge sake, but all these things is going to go out of your mind. By tonight itself, it's going to go out. So there's no doubt about that. So if you want to diagnose PFIC, only one point, that is deafness. So the question also tells associated deafness. You can surely go for PFIC type 1 because none of the other conditions are associated with deafness. You won't get deafness in any of the other types. You will get only in type 1. That is biolosis. Very common question in exam. So you get a young child, because why in PJ they ask us in PJ, pediatrics is something very important there. So that's why they ask a lot of questions based on pediatric scenario. That's why they ask this biology. This is a young child, like 3 years, 4 years, coming with family history of some liver disease, severe pruritus, diarrhea, vitamin K deficiency, suggestive of some ecchymosis in the skin, and the child is also having associated deafness. Think about Bailer's disease. So this is how you diagnose an exam. And the treatment is UDCA, liver transplantation. Sometimes they can ask this surgery, that is partial external biliary diversion, otherwise referred to as a cholecystogeginoecutaneostomy. So that's the other name for that. But nevertheless, there is an interesting association. Even though you think that bile disease is not important or this PFIC is not important, but there is an extremely interesting association with another disease called intrahepatic cholestasis of pregnancy. That's called ICP. That's also called as a benign intrahepatic cholestasis of pregnancy. So why I want to talk about this thing right now is because it has an association with whatever we have talked about till now. So usually ICP is thought to be due to the same defects, the same canalicular defects that we're talking about. So usually they might be having this BSEP defects, and they might be having this MDR3 defects. Usually ICP is also due to BSEP and MDR3 defects. So this is what is thought to be the reason for developing this ICP. So this patient with the pregnancy also having BSEP and MDR defects. So the why they should develop these defects in the first place in pregnancy, because they are strongly thinking because it is due to estrogen. So estrogen is what is strongly thought to be causing this intrahepatic cholestasis of pregnancy because of extremely high levels of estrogen. That is the same reason why if you take the previous LFT analysis and see, I'd have wrote that there are some conditions which produces cholestatic pattern, that I've written OCP. I told you multiple times OCP very important, because any estrogen containing pills, I mean even hormone replacement therapy estrogen can produce this cholestasis. So even though that cholestasis will not be called as ICP, but again the problem is because this estrogen induced BSEP and MDR3 defect, because we believe that estrogen can induce this BSEP and MDR3 defects. Because of that, they can result in development of this cholestasis. It could be any estrogen. Very commonly in pregnancy, very high level of estrogen you will see, but it can be seen in patients who are taking OCPs or hormone replacement therapy. For example, there is a relationship. How we know it's surely due to estrogen? Because these patients who have experienced intrahepatic cholestasis of pregnancy, if they take estrogen later in their life in the form of OCPs or probably hormone replacement therapy, they do develop cholestasis once again. There's a high risk of developing cholestasis. That's why that point is very important. It's very likely to be estrogen related defects in the BSEP and MDR3, and how they induce these defects we don't know. So previously it's called as benign intrahepatic cholestasis of pregnancy. Right now it's no longer called as benign, because this has a high risk of stillbirth. Increased stillbirth risk is there. At the same time, they increase the risk of premature delivery. So because it increases the risk of stillbirth and increases the risk of premature delivery, it's no longer called as benign ICP. It's just called as intrahepatic cholestasis of pregnancy. And the clinical feature wise, typically they'll present in the 3rd trimester of pregnancy, and they will be coming with severe pruritus. Pruritus is the most important problem here, and it will be usually severe, very severe, and typically happens in the palms and soles. And they'll be worst in the night. They won't be able to sleep at all because of this pruritus. And once again, if you see, this BSEP and MDR3 defects induce a lot of pruritus. If you see, even in congenital conditions, this BSEP defects and MDR3 defects induce pruritus as well. So that is the reason why even ICP patients come with pruritus. Again, the molecular defect is the key here. And these patients, as far as the enzymes are concerned, liver enzymes are concerned, these patients will have increased ALP. They can have increased ALP levels, but they can have increased AST and ALT levels as well. The most important aspect is to see that these patients have increased ALP, that is a marker of cholestasis. Plus or minus, they can have increased AST and ALT levels also. But remember, there is some association with GGT levels. So if you take the gamma glutamyl transferase levels, it can be normal or increased. Even though simply I told you it can be normal or increased, again it is based on the underlying defect. Suppose if the patient is having a BSEP defect, typically the GGT levels are supposed to be normal. In MDR3 defects, the GGT levels will be increased. But all of them will have elevated ALP. Without elevated ALP, how can I diagnose a cholestatic pattern in the first place? So they will come with cholestasis, they will have elevated ALP, there is no doubt about that. AST, ALT can be elevated, plus or minus they can have even elevated bilirubin. Most of it will be conjugated type only, more than 50%. That and all is not a problem. So this is not very important here. But most of the patients will present with elevated ALP, that is more than 2 times the upper limit of normal, which makes me diagnose it's a cholestatic pattern. That's why we called as a intrahepatic cholestasis of pregnancy. So why we call intrahepatic? Because ultrasound will be normal here. So there will be no dilation of the biliary radicals because it's drug related. Probably it's hormone estrogen related defects. So ultrasound will be normal, suggesting it's an intrahepatic cholestasis and not a extrahepatic cholestasis. As far as treatment is concerned, only one treatment, as I told you. Here it's a transient disorder, so you can give UDCA. It is extremely effective. Ursodeoxycholic acid thins the bile so that the bile flow will be very easy with UDCA. That's the reason why we use UDCA in many cholestatic states. But nevertheless, UDCA is hepatoprotective. At the same time, it is extremely effective. It can reduce the bilirubin as well as it can reduce the ALP as well as it can reduce the bile acid levels in the blood. And one more important thing is you need to do serum bile acids as well, apart from the enzymes. This has a prognostic value because these are bile acid export protein. Many of the times you will have a BSEP transport defect only, where bile acids levels in the serum will be definitely elevated. If you go back to the congenital causes also, if you see the serum bile acids are elevated in all these three situations, which means serum bile acid elevation is a common feature of intrahepatic cholestasis of pregnancy as well. So serum bile acids will be elevated, but how much serum bile acids are elevated, it's actually is a prognostic marker as well. So how it can be used as a prognostic marker? Suppose if the serum bile acid levels are more than 40 micromoles per liter, this is a value that I know very commonly because we see a number of cases, tremendous number of cases of ICP. Every month you can see at least one, because my hospital is a pediatric hospital, we see a lot of antepartum, postpartum case as well, where majority of the times, even many of our staff nurses who get conceived also come with very high level of serum bile acids because of ICP. Because this level of more than 40 is associated with increased risk of adverse fetal outcomes. So my idea is to give UDCA and to bring this serum bile acid level to less than 40 and make sure that there is no adverse fetal outcome. It's a very important treatment as well. So more than 40 is an indicator of high risk of adverse fetal outcome. And recurrence rate. Suppose if a patient got ICP in one pregnancy, the recurrence rate is approximately 60 to 70% with subsequent pregnancy. And at the same time, there is a 60 to 70% chance this cholestasis can happen when they use oral contraceptive pills, or probably they use hormone replacement therapy as well. So there is a high chance of recurrence rate. Almost 2/3 of the patients will have recurrent disease. 60 to 70% chance of recurrence is there in subsequent pregnancies. At the same time, 60 to 70% chance of recurrence while they are using oral contraceptive pills or while they are using hormone replacement therapy. So what are the important points here? So ICP, clinical diagnosis, third trimester, severe pruritus, elevated ALP, GGT variable, we don't want that. Elevated ALP, typical cholestatic pattern, diagnosis of ICP is made where ultrasound should be normal. So that's how we diagnose an ICP. Second point that they might be asking is the serum bile acid more than 40 is indicator of adverse fetal outcome. So we give UDCA to reduce the serum bile acid to less than 40. So treatment of choice is UDCA. And it's a transient disorder having a higher rate of recurrence in the subsequent pregnancy, and they use OCPs and hormone replacement therapy. But nevertheless, it's not a contraindication for breastfeeding. So if somebody asks you whether is it a contraindication for breastfeeding, because mothers will ask for sure, because they know when you explain the mother, you tell the bile acids are mixed, they will think like bile acids are toxins, which is mixing in the blood, so that they believe that breastfeeding might be harmful to the child. So you can tell there's no contraindication for breastfeeding. You can breastfeed. So this is not a contraindication for breastfeeding as such. And second thing that we need to discuss is the Alagille syndrome. Alagille syndrome is basically a JAG1 defect which produces a variety of problems. We can actually dissect this gene in and out, and we can tell what are the problems you will get. But nevertheless, there's no time right now, no need to discuss in that detail. It's a typical JAG1 defect. Clinical feature-wise, they will be presenting within 6 months of age. Within 6 months, they will present typically with jaundice, failure to thrive, and they'll be having some cardiovascular complications, like some congenital cardiovascular defects. So most common, this is one of the PJ questions, most common cardiovascular complication in patients with Alagille syndrome is pulmonic stenosis, primary pulmonic stenosis. Whenever you think about a pulmonic stenosis, there are two things in exam that you remember. One is your Noonan syndrome, and second is Alagille syndrome. Williams causes supravalvular aortic stenosis. Noonan syndrome is the one that causes primary pulmonic stenosis, and second is Alagille syndrome. So in exam, whenever you think about a primary pulmonic stenosis in childhood, only two syndromes you have to think about. So Alagille, and second is Noonan syndrome. Both causes most common congenital, both these conditions, most common congenital cardiovascular problem is this pulmonic stenosis. And at the same time, this jaundice typically is due to cholestasis. And this cholestasis is due to ductopenia. What do you mean by ductopenia? Ductopenia means there is paucity of the bile ducts, which means the proliferation of the bile ducts will be less, which means the number of bile ducts that have formed in this congenital condition is less. So within the liver itself, that is the reason why they cannot excrete bile adequately and they develop cholestatic jaundice. So it's usually a chronic cholestasis, long-standing cholestasis will be there. And plus, they might be developing other problems like dysmorphic facies. And there will be something called a prominent Schwalbe line. And go back to your ophthalmology textbooks and see what do you mean by Schwalbe's line. So there's something called Schwalbe's line. So there will be a very prominent Schwalbe's line in these children. that is also referred to as something called a posterior embryotoxin. And you go back to the ophthalmology list. I think it's given in person itself. So where there is something called a Shelby's line that is prominent, and that's called a posterior embryotoxin that is seen in Alagili syndrome. So dysmorphic faces may be there. Apart from that, the patient may have very characteristic. This is again very common question exam, butterfly shaped vertebra. And usually, like we know our NEET PG aspirants are very, 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 very fond of this kind of named things. So butterfly shaped vertebra, that butterfly shaped vertebra is basically due to the persistence of notochord in certain vertebra, which actually prevents the fusion of the lateral halves of the two vertebral bodies. So the vertebral bodies from both the sides should get fused to produce a single solid vertebra. Usually there will be a central notochord that will disappear, that makes the vertebral bodies from both the sides fused together to form a single vertebral body. But in certain vertebrae, you might actually have a poor, persistence of the notochord, and remnants of the notochord will be there that will prevent the fusion of the vertebral bodies. So the vertebral bodies will look on the side like this without getting fused. So there will be notochord you can't see in the beginning, in the center, but there will be a presence of notochord that cannot be seen. But you can see unfused vertebral bodies on the side, which looks like a butterfly. So that's how you get something called a butterfly shaped vertebral body. And remember, butterfly shaped vertebra is not only diagnostic of Alagili syndrome once again. So this is a DD for, one is Alagili syndrome we discussed already. And second one is spina bifida, especially the anterior spina bifida. In these conditions, you can see butterfly shaped vertebra. And third thing, I think you see in something called a Charcot-Levin syndrome. You can see in Charcot-Levin syndrome as well. So these are three differential diagnoses, but one of the common things that you need to know for exam is butterfly shaped vertebra can be seen in patients with anterior spina bifida as well. So these are three things that you need to know. And treatment, definite treatment is only liver transplantation, and it's a congenital problem. So many things has to be done, and it's a condition that is associated with a little poor prognosis. So that's what is important to know. I think we have discussed about the congenital causes of hyperbilirubinemia as well. With this is going to mark the end of the today's session. From tomorrow, we'll be discussing on the cause of acute and chronic hepatitis. At the same time, problems that happen due to cirrhosis, and if there is time, we'll be discussing on hepatocellular cancer as well. So with this, have a good night, and we'll see tomorrow. Bye-bye.